With this particular topic, I'll note that this discussion can sometimes feel very personal. That's not at all the intention. I would encourage you to kind of honestly consider your own practice and how you got there. Maybe question your assumptions as we go through some of these cases. We're going to see some very interesting data that Dr. Goldman was able to collect. Along those lines, our two guest speakers today, Dr. Sarah Goldman. Most of you know Sarah. She spends most of her time at Southern Maryland, but completed the Health Policy Fellowship with us in 2020. And Dr. Rahul Bhat, the Director of Informatics and Operations Improvement. Sarah, I'll turn it over to you.
So today we're going to be talking about unwarranted practice pattern variation. If you can imagine for a moment that you are all in your first week of your first year of training. The first patient that you see comes to you with a chief complaint of headache. They're young, they don't have any medical problems, their history is not concerning, their physical exam is normal. And you present to your attending and you say, I think they may need a head CT, maybe some labs, and some morphine because they have a severe headache. And your attending says to you, no, I don't need you to get any of that. No head CT, no labs, just give them some Toradol. After Toradol, patient feels better and they go home. The next day, you have a new attending and your first patient of the day, same situation, young person with a headache. Their history is not concerning, their exam is not concerning, but they have a severe headache, and you say to your attending, I don't think they need a head CT. I don't think they need any labs. I've already put them in for Toradol, right? And your attending says to you, well, let's get some basic labs, at least a white count, because I want to see. And I really already put them in for a head CT. They're actually down at the scan already, and I hate Toradol. Never give Toradol. Right? We have encountered this kind of variation a lot, right? And every patient is different. We as attendings are different. So we can expect there to be some small variation in the way that we practice medicine. But the reality is there's not just a little bit of variation, there's actually a huge amount in variation. And some of that variation is actually unwarranted. And what do we mean by unwarranted, right? It's a variation in the utilization of health services that cannot be explained by variation in patient characteristics or preferences. And unwarranted practice pattern variation exists in every state, every region, every hospital, in every specialty. And it exists even after controlling for patient acuity, provider experience, time of day, all sorts of factors. So we know that there is a lot of this unwarranted variation. And the question is, does it actually matter? We're going to be talking a lot today. We're going to be talking about a lot of different points, but if I can really have you take home 3 main learning points, it's this. Unwarranted practice pattern variation contributes to harmful and costly care. The root cause of variation is not what you think, right? Changing behavior we know is difficult, but probably necessary. And as we've kind of already alluded to, the goal of this conversation really isn't to shame anybody, but I want everyone here to commit to the idea of being wrong, right? Whether you've practiced emergency medicine for 30 years, whether you're ED ICU trained, or whether you're brand new, all of us are wrong in the decisions that we make every day. The goal here is really to identify meaningful solutions and to decrease that unwarranted variation. Now, why does this actually matter? I've already talked about costs and harm. So this statistic is old, so you can imagine it's actually much higher now, but we all know that in this country, we spend a lot of money on care, and relative to other places, we have poor outcomes. So in 2013, the Institute of Medicine estimated that about $210 billion of the $750 billion in waste is from unnecessary services, right? So we know that that number is a lot higher now. The bulk of these unnecessary services are not what we think, right? They're not these really expensive ortho procedures. Most of it comes from low cost, high volume health services, right? So the millions of PT, INR tests that we order when they're not actually clinically relevant. We also know, unfortunately, that in the past 5 years, about 50% or more of Americans have gone into debt because of medical and dental bills. We know that patients in debt are not filling their prescriptions, they're not going to their follow-up, they're coming back to us in the emergency department. The other final really important thing to understand is a lot of Medicaid and Medicare actually denies hospital claims, right? So about 18% of all claims are actually denied. So you may think that you're admitting a patient with, a very justified reason, but actually those claims are getting denied. And sorry, I didn't realize that my camera was actually off.
Yours is on, Sarah.
Oh, okay.
Yeah, yours is fine. It was that was to everybody else. If the folks are able to put it on, no, you're doing great.
Okay. So let's move on to some of the harms that we may actually not appreciate. So there are lots of examples of harms. I just picked some that are really relevant to our practice. So we know that in the past several decades, the rate of CTPE testing has exploded, but the rates of mortality remain unchanged. We know that the rates of diagnosis of these subsegmental and segmental PEs in this country have gone up. I'm guilty of this myself, right? It's hard for me to discharge someone with a segmental or subsegmental PE. Unfortunately, about 40% of these positive subsegmental and segmental PEs are actually a false positive. And we know once somebody has a, quote, positive PE in the past, they get admitted, they get started on anticoagulation. That anticoagulation is expensive. And then anytime they come back into care with chest pain or shortness of breath, the likelihood of getting tested again for PE goes up. There is a high rate of false positive stress tests after a negative ED cardiac workup, right? So people coming into the ED, they have chest pain, they have a concerning story, but their workup tropes, EKGs are negative. What do? We feel compelled to send them to cardiology. What does cardiology do? Well, they got sent from the ED for this emergent or urgent workup. And despite this negative workup in the ED, they send them for a stress test. This stress test is positive. It's actually 80% falsely positive. So we can imagine the downstream ramifications of this positive stress test, right? How many of us have had patients with 4, 5, 6, 7, 8, 9, 10 stents, right? And then also important, I think, to mention is that imaging and testing can be actually also falsely reassuring. We have patients come in, for example, with really bad cellulitis. We're wondering, is this neck fash? We get an x-ray, there's no gas, we send them home, and we were wrong, right? Because what is actually the sensitivity of gas on an x-ray? It's low. So what do we do now, right? Because we understand that, providers believe 15 to 30% of all medical services are completely unnecessary. So why are we doing this testing? And the number one reason that is quoted is malpractice. Doctors are afraid that if they miss something, they're going to be sued. The reality is very few patients, even those patients who probably should sue, they don't. Malpractice is actually going down. And we also know that in states with really great, and by great, I mean favorable to the physician malpractice laws like Texas, the rates of unnecessary testing are the same, right? So it's not really about malpractice. The reality is, and we can obviously talk about this, the biggest cause of all of this testing and variation in care, and sometimes, like I said, lack of testing, lack of a workup, is actually due to fear, right? We are afraid of being wrong. We are afraid of being called out by our colleagues. We don't want to be the case at M&M. We don't want to, get the call the next day, oh, your patient came back and they were sick, right? So a lot of this is really rooted in fear. And studies time and time again have shown that among providers identified as more conservative, more testing, more admissions, they even have a higher rates of variation than people who identify as less conservative, if you will. So now we're going to turn to the bulk of this talk, which is on the survey. And I don't know if we can pull it up, Munish. There's a lot to be garnered from the survey, and we can send it out. Thank you to everyone for responding. And as we move through it, I just want everyone to think about, what is the clinical value of the test that we're doing or the admission? And again, how do we decrease unwarranted variation to improve care quality and, when possible, unnecessary cost?
So Sarah, I put up the survey results. I just have a quick question, because I think one of the things that I'm hearing you say is that the biggest root cause of variability is risk tolerance, or maybe the variable is risk tolerance. Would you say that that's true?
Yes.
And it's clinician risk tolerance, not patient risk tolerance.
Yes. And a lot of the studies they looked at, variation still exists, even controlling for patient preference.
Mm-hmm. And so I wonder at some point if you can talk about how one modifies clinicians' risk tolerance, but I'll let you, I don't know if you want to go right to the survey first.
And maybe I can just chime in also. Just I had a couple thoughts kind of like as we're thinking through this is it's risk tolerance, I think, not just of a bad outcome, but I think it's risk tolerance of other people thinking you're a bad doctor is partly what's driving this, is what Sarah's getting at, more than even malpractice. Because I think when we sign out to our colleagues, is kind of like a great opportunity to kind of think about people's decision making in their thought process, and just ask, like, what's your thought process in a non-judgmental way. And a lot of times it's just kind of, that's what I do, that's my practice. I usually admit SVT, I usually admit syncope, and that's often driven by, I make a rule in my mind that anyone who's over 65 gets a CT and an echo and an EKG and all these kind of things, and we'll kind of get to the testing for syncope. But I think it just becomes like standard practice for people, so that they're not varying from that, so that they're capturing all possible, in their mind, bad outcomes. And so that if someone sees the patient downstream, even if nothing bad happened, they're not second guess for, like, how could you have sent this person home without doing X, Y, and Z? And I think we're probably going to talk about this a little bit later on, but all of us have, I think, a variation in our own practice within the shift, depending on the time of day and how much we've eaten and how busy the department is. And we sometimes regress to kind of more what we perceive as conservative decision making when we're tired, when we're hungry, when we feel the department to be kind of like overcrowded, and so that, I think, colors some of the thought process going into this.
Yeah, all great points, Rahul. Sarah, and you are muted.
So now we're kind of moving on to the survey, and I really want people to chime in with their thoughts. And specifically, when we look at this first question, this is a very, very common clinical scenario. Person coming in with epigastric pain, they don't have any specific urinary symptoms. A urinalysis is ordered, maybe by triage, maybe by you. These are the results. Is anyone surprised that the bulk of people are ordering just a culture and treating off the culture? What do you guys think about the survey results for this first question?
Yeah, and Sarah, I'm happy to start. And again, I would say that this is, as best as we can, a judgment-free zone. So people, please feel free to share your honest opinions. I was shocked, particularly at the send the culture piece. I'm not saying it's wrong, but I worry about the amount of work that's adding to our colleagues of like who's following up on those cultures, and does that set us up for potential failure if we miss those culture results? So that was my big surprise when I saw these results. I don't know how others feel.
Yeah, Munish, I'll weigh in. I was similarly surprised, and I thought that we would see a pie chart here that had 80% plus deciding to do the same thing. This was a bit eye-opening for me. Not just this, but the other questions as well.
What do other people think? Because I think the neat thing about this is that it's all over the place. So it'd be helpful to hear from people who are kind of on the side of when a test is abnormal, you need to do something about it. Because I think that's kind of a common driver of what makes people feel kind of like they need to culture or treat or something along those lines. So I don't know if anyone responded on the side of kind of like no treatment in the ED, send the culture, or start on antibiotics for this patient. And again, this is a no judgment zone. We're just kind of like wanting to hear kind of like the thought process that drives some of this practice variation.
Hey, this is Jennifer Thompson. I think I said no treatment in the ED, send culture, and I can tell you that probably what led me to pick that choice is a case where a case that was reviewed where the patient had an abnormal UA, had other symptoms that may have led you not to think that their symptoms were a UTI, but then bounced back as a sick UTI. And the criticism was, well, technically that's a UTI. Their WBCs are over 5, and they didn't even send a culture. And I just remember that criticism of the case and thinking, oh, well, I might not have treated that UTI either. Maybe next time in a patient who has risk factors like diabetes, as this patient did, I should maybe send a culture, but I probably wouldn't treat it automatically. I probably wouldn't have treated it automatically either. So it's the fear of being seen as a poor doctor, and the bounce back case that I was part of the discussion of.
Jen, if I can comment on that, it's thanks for sharing first. Second, so powerful the words that we use in these discussions about these cases, in these in practice committee and cases and things like that. Like, it has such an impact on all of us. And I think you're exactly right. And you behaving the way we all do, if we are like maybe reprimanded is a strong word, but like told to maybe modify our behavior, or maybe we didn't do the right thing, it has a lasting impact, which I think is fascinating.
And I know someone in the chat wrote, why are we treating, why are we calling epigastric pain a UTI, right? And I think that's even something that is not agreed upon, right? Doesn't epigastric pain represent a UTI? For me, the answer is, probably no. And it is hard when we are in a system whereby other people are ordering a test that maybe we would not have ordered ourselves, but it's now recorded, right? It's already in the chart. And so it is easier for people, if there is a bad outcome, to look back and say, well, you did something wrong. And then the other important point, I think, is to say, there are a lot of treatments that interact. So you can see here patients on Coumadin, which does have a lot of interactions with the antibiotics. And one of the unfortunate or fortunate things, I don't know how you want to say it, there are so many hospital systems in DC. So there's a chance that patients are bouncing back, but we don't ever actually know that, right? And so I think that there may be side effects or harms that we're causing from our treatments that we will never even know. And so that's another challenge.
Yeah, and Sarah, to comment again on the question in the chat about why was the UA sent for epigastric pain, to your point, our system is set up where we make decisions and order tests with incomplete information. And you know, we all have incomplete information, but it's even more incomplete when it's done across the screen for a 90-second interaction.
Do we want to go to the next one, or does anyone have any final comments on this one?
Yeah, we can always come back to it. Oh,
I
please
have
go
just
ahead.
a thought on it. Munish, you mentioned, you know, you have some concerns about the additional work that's going to be put into following up on all these culture results. I wonder how much of an effect it has on people knowing that we have the abnormal lab callback program. And I think that's been a really great resource, but it does make me wonder, does the ease of sending those tests now make people more prone to send them? Because most of us, when we're working in the ED, we're not thinking about that longer term follow-up, the work that goes into that, and we're sort of taking that for granted.
Yeah, Sign, it's such a great point. It's a great resource that we have, but does the presence of it modify behavior? Does it drop the threshold to add cultures? It's an interesting question. All right, next case. And Sarah, you are muted.
So this is another case that we see, you know, every day. A elderly person, 70, coming in with, let's say pre-syncope and not syncope because he technically didn't lose consciousness, right? And his exam is fine, his testing is all fine. And we do see that a significant portion of people who participated are admitting this patient, right? I mean, 27.8% are admitting this patient. And then a lot of other people are doing head CTs, chest x-rays, repeat troponin. And then if that's all negative, are discharging. And then 42% are just discharging outright. So I'm just wondering, is anyone using like any clinical decision rules to figure out if they're discharging or they're admitting, or they're admitting because people are elderly, or what do you think is the cause here of the biggest discrepancy?
And any component of it, I mean, if it's admit versus discharge, if it's CT versus not CT, kind of what are people's thoughts as far as like anything aside from discharge, kind of what kind of thought goes into those decisions?
I mean, the way that I look at all of these cases is that as emergency physicians, we are pretty familiar with the literature, right? We don't treat asymptomatic bacteriuria. We don't need to treat asymptomatic hypertension. A patient who comes in with syncope, pre-syncope, the literature says we don't need a head CT. And so the bigger question is, it's not lack of knowledge, I think, for a majority of people, but fear is the major driver behind a lot of these decisions. And the fact that everybody has some type of an anecdotal, oh, you know, this patient presented, and then it turned out that something horrible happened down the line. And they anchor on that one experience to drive fear and practice further. So what I would have loved to have seen as one of these choices is, how about a deep conversation and shared decision-making between the physician and the patient, where the physician actually discusses, hey, you know, if you just passed out, this is what I'm thinking. This is what my thoughts are. Of course, none of us are 100% accurate. You're probably safe to go home. You're probably fine not to get a head CT. These are the risks and benefits. But and doing that shared decision making, having that be the another choice to these. And the question is time, right? That's the other big factor that comes into consideration. Is it just easier? And is our system built in such a way with teletriage that we don't want to miss anything? And so our system predisposes to ordering more tests because of our long wait times in the emergency department, waiting rooms. And so occasionally we pick up on an intracranial hemorrhage in a bizarre presentation, maybe syncope or something like that, because the teletriage provider ordered that test. So I think there's so many factors, right? And this is why it's such a complex question to answer. Sorry, too much.
No, perfect. You're right. It's so complex. Greg?
Well, the other thing to put into your 70-year-old male, when was he out mowing his lawn? Was it 95 degrees out, and and was it before lunch? Was it after lunch? There's so many little variables that I'm going to tend towards discharging this guy. I admit that up front with a little more testing than has already been done. But I feel even better being able to fully explain his symptomatology. So it was a hot day out. He hadn't had lunch yet. He recently had an increase in his dose of antihypertensives. There's so many variables that make me very comfortable discharging a home because I can explain in my documentation my thought process around why he experienced the symptoms. If I can't explain why he experienced the symptoms, it was a mild day. There was other variables in there. His blood pressure, medicine hasn't changed forever, and he's anxious or anything else like that, I may offer him an observation. But even then, I'm going to tend towards going home, but I'm going to document and feel better about doing it if I can go through the experience he had, essentially, and what led to that presyncopal episode, if that makes sense.
Makes total sense, Greg. Makes total sense. Hard to put into the stem of a question and the
Right.
answers of a question. But I think that's the clinician we all hope to be.
Yeah, and to be honest, I left them somewhat vague because there are so many variables, but also it to your point, it speaks to it's about comfort. How risk tolerant are you? If there's not a slam dunk, it was 100 degrees and he went running or participated in a marathon. Often we are faced with these gray zone cases, right? So it comes down to how comfortable do you feel with discharging this patient?
Honey?
I was just going to say, if I had this kind of patient and I didn't have the history of it's hot outside, it's not hot outside, it is a gray zone patient. But then, in my mind, sometimes I'm like, well, if I bring this patient in, you kind of know what's going to happen. You bring them in, they're going to get a cardiology consult. The cardiologist is going to say, get an echo. And so, you don't really see that the cardiologist is going to write a note and say, doesn't need an echo, discharge home, So I think that affects my, medical decision making kind of, if I see him bringing in patients and the cardiologist is like, no, patient's great, go home, without an echo, then I'm going to be more likely to discharge these patients without patient follow-up. So I think it's not, I know this is a discussion within the ED community, but I think, these sort of our consultants sort of impact our decision making as well,
Rahul?
Yeah, what's been kind of interesting, Hanya, is that now that we started doing OBS at hospital center, we're actually seeing a lot of the downstream stuff that gets done or needs to get done for patients once they get placed in OBS, and we're probably changing our practice to some extent in terms of hopefully admitting and OBSing fewer patients because we realize how little actually gets done downstream, because the echo part of it, cardiology, believe it or not, is actually reluctant to recommend for most patients getting an echo because they don't feel like it changes management, and they know how hard it is to get echoes in the hospital because we often start off Mondays at hospital center with 120 or so pending echoes across the hospital. So I'm hoping as more departments get OBS and you see like the fruitlessness of the downstream workup, that we might start changing our practice to not admit as many patients, because you realize like not a whole lot actually happens. And chest pain, I think, is a good example of that we think a bunch of stuff happens and it turns out they get a couple more troponins, they get another EKG, and they still get discharged. And so I think we're all more comfortable with discharging more chest pain, but we might do the same with syncope and a few of these other diagnoses.
Yeah, well, it's such a great point. I think if our residents, when they graduate now, learn so much more than I did when I graduated residency. The one thing that was, I think, beneficial 20 years ago was we did inpatient medicine months. and you saw it, and you saw how little you did for patients that were hospitalized for a day or 2 days from the ED, and they got discharged without any work, which our residents don't get exposed to anymore. Other comments or thoughts about this case? I was a little bit surprised at the number of folks who are getting repeat troponins, and I'm wondering if anyone would be willing to share the thought process there.
I can elaborate a little bit because I'm a PA and I work with many different attendings. So our workup often changes as we're discussing, and the rationale for admitting this patient is because, of cardiac or neurologic bad outcomes that could result. The rationale that I've been given for repeating troponin is the possibility of ACS. But I think my personal opinion is leans more towards, I think the echo on an outpatient basis is going to be more useful because you're going to identify valvular abnormalities. But in my practice, I have found that these types of patients, we do end up admitting most of the time in observation for the majority of our attendings and the PAs.
Thanks, Karen.
My suspicion is that people want a little more level of comfort, and they feel better with a flat troponin in a 70-year-old guy who felt lightheaded. I could question the value of the troponin in the first place on someone without any chest pain who was a little presyncopal. I'm not advocating for not getting the troponin, don't get me wrong, but I'm just wondering if there's a study for your team, is the above a certain age, and I'm not sure what that age is anymore, that what's the value of troponin in someone with no chest pain, in the presyncope workup? And does it muddy the water more than add any true diagnostic value?
Yeah, it is an interesting question. Other thoughts, or Rahul or Sarah, any other comments you wanted to make about this case?
Yeah, I guess just a comment on the head CT, because this comes up with syncope, but also with vertigo symptoms. That I think the thought process behind the head CT is that you're ruling out neurologic causes. And I think that kind of goes back to Sarah's point of sometimes we do a test that falsely reassures us. So by getting a head CT, it doesn't rule out anything neurologic. It just says they didn't have a head bleed. They're not likely to show a stroke, I think, based on this presentation, because the patient has no deficits. And so it'd be unusual to see something on the head CT. But I think we feel better saying that we've done a head CT to say this wasn't neurologic. We've gotten a couple of troponins. It's not cardiac. So now we feel comfortable discharging them. So it might be that people are doing this to buff their chart to say that now I feel better about discharging them. But I think we may want to reconsider that practice, just because it might lead you to almost get into more trouble in the sense that you were thinking something neurologic, but you haven't ruled anything out. Kind of similar to getting a non-contrast chest CT on someone with chest pain when you're really suspicious of a PE, that it just didn't answer the question at all. So it might be better to have not done the test, or write in your documentation as to why you don't think it's a PE or why you don't think the patient had a stroke.
Yeah, a comment and a question. The comment that this was a practice change for me after, I think, a deep conversation with Greg at Sign Out, when I had somebody where I think it was one of these things where I was taught to get a head CT on all these patients in residency, and Greg questioned that behavior in an academic discourse kind of way of like, what are you looking for? And it just made me think exactly what you're saying, Rahul, of like, if the person is normal neurologic now, what am I expecting to find? There should be nothing that we would see that transiently would cause someone to, lose consciousness or come close to losing consciousness that is still present if somebody's now awake, alert, talking, and neurologically normal. The other question that I have, though, is do you think that some of our practice is influenced by those to whom we admit? Of, if you do choose to admit this person for whatever reason, it's what did the head CT show? Or please get the head CT before they come upstairs.
I think that's your point about the head CT before they come upstairs. That does happen, and I think people do that when they decide to admit. I agree with that. It's funny too how you're also influenced by your peers, right?
Yeah.
When I started in this practice years ago, this patient pretty much was a slam dunk. Yeah, bring him into observation. 70-year-old, cardiac history, and I think the factors to that at that time were there was a lot of factors, but one included also we didn't have boarding at that time. We had beds. The hospital wanted to put the patients in the beds. I mean, let's admit this, it was, and no pun intended, let's admit this. And so it was just easier from our disposition and, standpoint is that was the expectation is someone with this type of thing would go to a hospital bed for further evaluation. As times have changed and that resource has become more limited, we started questioning that practice overall. Same thing for the low-risk cardiac chest pains. Those were slam dunk, put them in observation for Q8-hour troponins, remember? You couldn't tell anything without, 24 hours of tropes. So I think our practice overall, emergency medicine and MEP's practice has evolved in a good way over the last 20 plus years because of limited resources. Part of it is limited resources and making proper use of those limited resources for the patients that really benefit from them, if that makes any sense at all.
Kelly?
I think one other factor is how easy is it for the patient to follow up. Sometimes they may already have a cardiologist there that you can directly communicate with. And also, the patient's history. Have they had this before? Have they had a complete workup? Is this a patient that hasn't seen a doctor in 20 years, but, this was something that brought them to the ER? Those all are small factors that contribute to whether I want to discharge them versus bring them into OBS.
Great. Sarah, if okay, I'm going to move on to the next case.
So I think this was one of the more polarizing questions, which is fascinating. 65-year-old coming in with asymptomatic hypertension sent in by an outside clinic. Blood pressure is 220/95, but she has absolutely no symptoms. And again, something we see every day from our colleagues. I've had a guy last week, he was waiting for a GI appointment for like 5 months. He finally gets to the appointment. His triage vitals were high and hypertension, they sent him to the ER. And it's like, I sent him home immediately, which he was frustrated by and I was frustrated by. So we are faced with kind of pressures to either order blood work or to lower it. And again, as you'll see in the answers, everyone has a different, magical number for which they are discharging people. And I'd love to hear you guys' thoughts about, do you discharge these people immediately? Do you try to lower it? Like, do you have a magical number? And how do you think we can maybe as a group come to a consensus to have patients stop coming in for asymptomatic hypertension?
Dan?
No, I agree with you. I was shocked to just look at that number. I mean, after all this time that we've been telling our hospitals and our primary care physician not to send these patients here, and like at least 12.2%, even more people, 70, or like a total of, well, less than 50, more than 50%, right? Somebody's doing something. And it was a little shocking to me. I personally wouldn't. I don't do anything with this patient. I just send them home, and maybe I give them a prescription if I'm gonna have somebody follow them. But that's pretty much it.
Lindsay?
Yeah, I tend to agree kind of with Dan. I don't do a whole lot for these patients. I, often will send the BMP just to technically say there was no end organ failure, or if their creatinine is a little up, maybe that will change my medication selection. But anyone who's worked with me at Southern Maryland has probably heard me rant about the number of asymptomatic hypertension patients who get EKGs in triage. And it's one of, I think, the most frustrating things I see every single shift, because they're absolutely asymptomatic, and then you get this EKG that has some T-wave inversions, and you don't have any priors for comparison. So now they're getting a troponin, and then it just like spirals to unnecessary test after unnecessary test. And so I don't know, EKGs for asymptomatic hypertension are probably my biggest pet peeve with this kind of patient scenario. But I tend to fall in the maybe a quick BMP and then discharge home with oral antibiotics and follow up.
Greg?
Yeah, it's funny to hear people say I don't do anything and just discharge them home. I would argue that I do something. I sit down, I talk with them briefly, ask them what medicines they've been taking, what they shouldn't be taking, why they're not taking them, and I offer them a dose of the medicine that they missed that morning for whatever reason. So I think we should get away from saying I don't do anything, I just send them home. No, I think we do a lot. We help educate the patients, and we should take ownership of that as a group. And part of that education is, yeah, this is an elevated blood pressure, and over time it can cause problems, but it's nothing you need to worry about right now based on this one number. And I think that's just as important as anything else.
I'm in the same camp, but one caveat I'll kind of just add to this is that I think everyone has their number, though, at which we would cringe at discharging this patient home. And I think we set it kind of intentionally at the mark that many of us would still feel comfortable discharging the patient. But if they came in with 260 over 140, I don't know. I kind of might rethink that thought process. And so I don't know that it should, but I don't know that that population has ever been studied. I remember, Lindsay, one of your classmates, Travis, would actually like hold out for like, I'm waiting for an attending who will let me discharge a patient with a blood pressure of 300. And I was like, is that a good thing? Or I don't know. Like, I don't know the answer to that, but I'm just going to throw that out there because I think had the number been set lower, I think a lot of us would have potentially discharged the patient, but 220 is beyond their line in the sand for some of us.
I think 260 over 140, all of us would at least repeat the blood pressure.
Yeah.
It's just a number that looks bad on the paper. Let's admit that. Even though the patient's asymptomatic, that number in and of itself looks bad. So that would warrant at least a repeat set of vitals. And I would also wager 87% of the time, it'll be lower when you get another set of vitals.
It's also somewhat unusual to have a patient who has absolutely no symptoms. I find that once they're asked about headache, dizziness, shortness of breath, and so forth, they start to really analyze themselves, and they suddenly develop symptoms. And I think that puts us in an even tougher spot. And lastly, when they're sent to the emergency department by somebody that they might trust or respect, and I think the fear is that if we do nothing, the patient will not trust us, or they will be angry, or they will be frustrated. So I think that what Greg mentioned, the sitting down, discussing, explaining long-term hypertension versus short-term management of hypertension, what that really means in terms of the blood pressure today versus that blood pressure over years, and what the individual who sent the patient to the emergency department might have been afraid of. I think that's all critical, and that's probably the most important thing that we do with all of this, is to get the history, figure out why non-compliance. Is there a lack of funds, knowledge, follow-up? How can we help with those aspects in terms of social work, patient navigators, information, education in general?
And here comes Dr. Waters to say that she starts everybody on a narcotropine drip and puts them in the ICU.
Been there. No. I was first of all, I just wanted to I answered discharge, and I think I would offer their home PO med if they'd missed it. Otherwise discharge. But I think I'm new to practice also. But I think where I struggled the most is when I think like Diana just said, when they're sent in by another clinician. I had a patient that was sent in by their cardiologist actually for asymptomatic hypertension. And I got a wild hair and called the cardiologist and asked if there was anything in particular they were concerned about. And the word liability and bring the diastolic down with a squirt of IV antihypertensives, all those words were mentioned. But that's where I think I struggle without doing anything and getting like a repeat vital sign that's better is when they're sent in by somebody in clinic.
Yeah, Jess, I think it's a great point, right? Because maybe it's different if they were sent in by their ophthalmologist or their pharmacist or their, the podiatrist, no disrespect to any of those professions, versus their cardiologist or their primary care doctor, where maybe it feels like we need to do more. But to Diana's point, I mean, maybe that is part of the value of just getting the BMP to make sure they don't have renal failure. I don't know. I think it's up for discussion. Dan?
Yeah, so my experience is even when the cardiologists are sending them, they're not really giving you any guidance. And we also have to kind of talk about the harm that we can cause by lowering the blood pressure. It's not just not wanting to do something. And I agree with it 100% with Greg. I mean, we do a lot with this patient, whether it's social, connect them with patient navigator to make them an appointment or to give them a new prescription if they don't have it, and advise them to take a medication, sometimes just because it caused them some side effect, whatever the reason that they might have taken it. But again, we have a lot of cardiologists that actually send the patient to ED just because some of them are a very good friend of mine. I've never found any good reason why they specifically send them to the ED other than just, I'm not sending a patient home with a 240 systolic. I'm like, okay, what do you want me to do? I don't know.
Well, I think there's 2 points to that. One is risk transference, the fear of accepting some degree of risk and not doing something. The other is sometimes I feel like I hear I got sent by my cardiologist, whereas it wasn't the cardiologist, it was the cardiologist's tech or receptionist or maybe nurse that sent them in. Nana, I think you had a question, but I'm not sure if you still do.
Yeah, you made a point I was going to make, that coming from the office doesn't mean that the physician themselves have actually seen the patient. It's anybody in the office could be sending them without regard to the number. They see a number 200, like you have to go to the ED. And maybe if the cardiologist has seen the patient, they would have done something completely different.
Yeah, I mean, and we see the same thing. And sorry, Nana, go ahead.
For these patients, I think the secondary prevention is where I think most of us, like myself, focus on to make sure, yes, they are here today. How do we make sure they don't come in next week or next month? So if they don't have primary care, let's get them into primary care. And personally, if they are not previously diagnosed hypertensive at certain blood pressure number, I will start you on long-term medication. After I've arranged somebody to follow up, I could give you 3 months supply of an initial starting dose after I've arranged for somebody to see you within that period to ensure that this person is not showing up in a month time with the same problem.
Yeah, totally agree, Nana. And I think most of us are familiar with the $4 Walmart list for medications, which include several antihypertensives for those who have difficulty getting access for cost reasons. Shall we move on to the next case?
Okay, so this person comes in history of diabetes for skin changes, and we know that they have cellulitis, but otherwise clinically looks well. The reason I wanted to include this is because we obviously miss a significant portion of neck fascia. I think that's always on our mind, with the caveat being that almost every patient that we have has diabetes, right? So what do we do when a patient comes in with what we clinically think is cellulitis, they have diabetes, but they look well? And And it looks like a lot of people are ordering x-rays or scans, and even a significant amount of people, despite a negative workup, are still admitting the patient. And so I'm curious to hear what you guys think about the reasons behind ordering the tests for simple cellulitis. Is it because they have diabetes, or do you think that having testing is the right thing to do or not the right thing to do? I'm curious.
And Sarah, just to comment on this, I would say this is probably the hardest one as a question format because you can't see it, right? You can't see it, you can't feel it. So it might be the most difficult one to get in to respond to accurately.
I think the other comment is it's 12:54. So
yeah. So is it okay if we just move on to the last case?
Yeah.
Okay, great.
I wanted to include this last case, thinking about sometimes we should be admitting if we don't, or, how do people approach this, again, common case of dizziness in a young person with a poor EF, no ICD, who comes in with, again, pre-syncope. And are people surprised by the high admission rate or the relatively high discharge rate in this case?
Yeah, I can start with that. I was surprised at I think it's somewhere around a quarter of folks were discharging this individual. And I think my primary concern is somebody with an EF that low. I worry about developing VT or VF, and that being the etiology for this person's syncope.
And you almost wonder if the reason that so many people were discharging this patient is that the prior 4 questions were kind of like pushing them in the other direction, like you should be doing less.
But I think it's an important point when we talk about variability, right? I think that is often the message that's heard of, discharge more people, do less tests, whereas I don't think that that's the entire message. And Sarah, I don't know if you want to comment on that.
Sure, but Lindsay, did you have something?
I was going to say, I also could see this case as one potentially differ for me based on like where I was in my shift. Like, I have to admit that I don't think anybody would fight you on this admission, and I think it'd be very reasonable to admit this one. And I think towards the end of my shift, hands down, I would just admit this. Whereas, I don't know, I wonder if I saw this early in my shift, would I do a few more tests and kind of do an ambulatory trial and talk to his cardiologist? And I don't know, I definitely own variation on this one, potentially depending on where I was at in the shift and kind of, what my bandwidth was at that moment.
So many of these cases depend upon how accurate the past medical history is and how much time we have to obtain the past medical history. Because if we really have time to do a chart dissection, speak with a cardiologist, find out when the last echo was. Has he ever had these symptoms before? What happened before? What type of a workup was it? Is the cardiologist able to follow up promptly? Then, we might consider discharging the patient. But if they haven't seen their cardiologist in 3 years and we don't know what their latest EF is, and on and on and on, then admission seems like the absolute slam dunk right decision.
Yeah, I can just give you my 2 lines, and I think, Sarah, I'm sure you got more to say also, but if anyone has like a burning interest to kind of like help us to make our practices kind of more aligned, easiest way to do this is propose it to either me or Daniel as a topic for discussion at our operations committee, because we have many of these clinical practice guidelines that come from this in terms of chest pain. We're working on a CHF one. We worked on a outpatient management of PE, for example, so that we can kind of have a little bit more consistent practice across all of our sites. So I think syncope and SVT were two that were recently brought up. If anyone has an interest in working on either of these, please let either Daniel or I know, and we'll bring it to our operations committee to come up with a CPG. But those things I think will help in terms of you feeling kind of more protected that you want to send this person home, but you wanted some guidelines to kind of back you up. That's one of the ways of kind of achieving that. So please let us know.
Yeah, I will say, obviously, all of us are just trying to do the best thing for the patient. We do face a lot of external pressures to, treat a patient, even though we know that it may not be the most helpful. I'll just ask for MEP leadership if we can also continue having this conversation with our outpatient providers about the clinical utility of sending people in for certain situations. Like, it does help us when we know maybe the inpatient workup is not what they would expect. Maybe if they knew what maybe the ED workup is, they would be less inclined to send them in. And also what hospital, nursing, and other specialties, if we could also have a conversation with them about maybe the low utility of CT, lowering blood pressure upon entrance to the floors, et cetera, it would also make it easier for us to decrease this variation.
Hey, Sarah, great points. First of all, great presentation. Thanks to you and Munish and Rahul. Great discussion. These are nuanced discussions, right? Nuanced points, as evidenced by the fact that we are all not in agreement about how to manage some of these patients. And so, it becomes even more difficult when you start adding in other service lines. Having said that, we have taken the opportunity to do this on occasion. One example that comes to mind is we were having patients sent from anesthesiology, for same-day procedures, come in, the patient is hypertensive and they're coming to the ED. We took this not to sort of local leaders, but rather to the, Daniel spoke on our behalf, but took this to the anesthesiology clinical practice council and said, hey, stop doing this. We're not doing anything for these patients. Stop sending these patients to the emergency department. And we've seen significant reduction, still not perfect, but significant reduction for those types of patients. So I think the infrastructure is such that, yes, it is appropriate and there are opportunities to have those communications. Not every service line has the structure in place like we do to disseminate these messages to everybody all at once in a coordinated manner. I think of primary care, that's just by the nature of their practices and various geographies, et cetera, it's a little less organized, and so those messages don't quite cascade like they might for emergency medicine. But it doesn't mean that we can't work to do that. So what I would ask, what we might consider doing is, generate a list of what are some of those things, some of the take-home messages, examples from your talk would be good ones, to take, to our colleagues in other service lines and say, hey, listen, we'd love for you to stop sending patients, to your primary care doctors, stop sending patients with asymptomatic hypertension to the emergency department, for example. So if you or others, and maybe this is something that the operations subcommittee to the CPC can work on with Daniel and Rahul as the leaders of that, with you, Sarah, and others that might be interested. Let's generate a list of what we think are those messages and who might be the appropriate recipients of those messages. And we're happy to do that. I'm happy to do that and be the messenger for that group.
Great. All right. Well, thanks, everyone. Thank you, Sarah. Thank you, Rahul, for leading this really great conversation. And thanks to all of you for participating.